Hello, my name is Ravi Vij. I am here, and today we have Dr. Samir Hadidi, Associate Professor at the Myeloma Center at the University of Arkansas, a leading center for myeloma for a long time. And he's here today to discuss results of the AQUILA study, of phase 3 trial of Daratumumab versus active monitoring in high-risk smoldering myeloma, which was presented at the American Society of Hematology meeting in December 2024 for the first time. So welcome, Samir.
Thank you so much for having me.
So let's go ahead and review the trial, and then we will talk about how you intend to incorporate this in your practice. So can you tell us about the trial design?
Yes, certainly. AQUILA study is, an international phase 3 clinical trial that included patients with smoldering multiple myeloma. The definition at that time when this study was done was a little bit different than what we consider as high-risk smoldering myeloma nowadays. But that included patients who got diagnosed with smoldering myeloma for less or equal to 5 years. And they have certainly some features that may resemble high-risk smoldering myeloma, including immunoparesis and involved free light chain over uninvolved of above or equal to 8, and clonal plasma cells of more than 50 up to 60%. And as you can see in the slide, 390 patients were randomized to get either daratumumab or active monitoring in one-to-one fashion. The daratumumab dosing is quite usual for what we use in myeloma. It starts weekly for the first 2 cycles, then every other week for the 4 cycles, and after that, once every 4 weeks for a subsequent cycles up until 3 years. And those patients were followed for progression-free survival, and secondary endpoints were including overall survival.
So what can you tell us about the demographics of the patients accrued?
So as you can see in the slide, those patients were typical of the smoldering myeloma patients we see in clinic. So patients were older. Vast majority of patients in this study were 65 or older, almost 50% in both of those groups. Mostly those patients have ECOG of 0 to 1. Typical to most of the clinical trials we have nowadays. And I think one important thing is to highlight that those patients were randomized after a little while of being diagnosed with smoldering myeloma. You can see it was 0.8 years, but up to 4.7 years from the time of diagnosis. So this is maybe a little bit different than what we see in clinic, where you get a patient just got diagnosed right now, which is close to 0 time sort of in clinic. And those patients, have relatively low volume of plasma cells in the bone marrow, around 20%, with a range up to just less than 60%. And the most common subtype is, as usual, we see in smoldering myeloma, which is IgG subtype, then IgA subtype as the second most common.
And what else do we know about these patients and their risk?
I think that's very important sort of slide here to look into a few things. First of all, and to the risk factors that we consider for patients with smoldering myeloma. So most of those patients have less than 3 risk factors as defined by the study. And as I mentioned, this is a little bit different than what we nowadays think. For example, IgA smoldering myeloma by itself is considered to be a risk factor, and the involvement of free light chain above or equal to 8. For example, per the updated Mayo Clinic criteria, which you can see in the table, free light chain ratio is usually thought to be above 20 to be considered as high risk. So in a sort of a a retrospective fashion, those patients were looked at in the Mayo Clinic classification, and there was around, up to one third of patients considered to be high risk per the Mayo 2018 criteria. And if you look at the cytogenetic risk, also, there is around anything between 15 to 17% of patients considered to be high risk per this feature. When we look at the actual treatments given, most patients who are in daratumumab were given, a treatment with daratumumab being followed for close to 3 years, while patients on active monitoring were followed to, on average, to up to 26 months. And you can see actually that patients who stopped either of those treatments or arms, to be more accurate, were mainly related to progression of their disease. So more patients with active monitoring were taken off the study because of progression of disease, but there is a sizable number of patients in daratumumab were taken due to adverse events, and that is around 7% of patients. There are around 2% of patients who were taken off, for example, active monitoring due to death, while it was only 0.5 in the cases of daratumumab. So that's kind of a good sort of way of looking how those patients started and then how they got the treatment allocation and what happened to them.
So what was the bottom line? What's the punchline?
So as you can see in the Kaplan-Meier curve, and this is where the progression-free survival, patients who were randomized to get daratumumab have lower, events. Patients with a median follow-up of close to 65 months, you can see that around 79.9% of patients in the case of daratumumab were still, not showing any progression compared to 63.3%, and then with the median progression survival of not being reached in the case of daratumumab compared to close to 42 months in case of active monitoring. I think this is probably one of the most important tables in the whole study, and the reason why is that many people who are advocating for treatment of smoldering myeloma advocate for that because we worry about bad things to happen. And that includes, for example, fractures, bone disease, or renal failure. And those are kind of risky things to wait for a disease to cause. And you can see that reassuring results of having 0 cases of renal insufficiency in both arms, as well as similar numbers of bone disease according to where you look. So for CRAB criteria, you can see that there is slightly higher amount of bone disease in the active monitoring, but in the slim CRAB criteria, which is looking at MRI, you can see that there was a little bit more focal lesions in the daratumumab arm compared to the active monitoring. So those numbers kind of equal each other, and bone disease or more than focal lesions on MRI are quite similar between both groups. So I think this is important in 2 aspects. First, to say that both renal insufficiency and bone disease are quite similar in both groups, and most of those events has to do with either anemia, slim CRAB criteria, and elevation of calcium. And when you look at the death, I think it's very important to look at the fact that 67 patients in the daratumumab arm, died compared to 99 in the active monitoring. So there is numerically high amount of death in active monitoring, and there's some of those were actually without progression of disease, specifically in daratumumab arm. So this indicates that using daratumumab, which is an active agent in myeloma, to actually decrease the chances of developing myeloma in patients with smoldering myeloma, with this long follow-up.
And what about subgroup analysis?
So I think that's important because we want to see if this, benefit is across all groups. And I think one of the important ones to look into is the Mayo Clinic 2018 risk criteria, because this is what we think nowadays is the currently high risk smoldering myeloma patients. And you can see the hazard ratio is rightly the lowest in case of high risk Mayo 2018 subgroup analysis at 0.36. So those patients seem to be the ones that drive most benefit, are the ones with this highest risk bear the Mayo Clinic criteria. But this, benefit seems to be, there in all subgroups, including, patients, for example, who have baseline renal function problem. Those still actually get benefit, as well as patients with cytogenetic risk. But I think this subgroup analysis tell us that those patients with higher risk to develop myeloma from smoldering myeloma seem to derive the most benefit.
And what can you tell us about response and progression on frontline treatment?
So I think that's very also important slide there. So for example, when we use daratumumab in patients who got randomized to daratumumab, not all patients do actually respond to treatment. 2/3 of patients respond to treatment, compared to close to 0% of patients in the active arm responding to treatment. And I think that is, that's evident there that most of those responses are either partial responses or very good partial response. So, for example, in contrast to what we have nowadays with myeloma, where use of quad, for example, give us, a close to 50% CR or better, you can see here a little bit lower, responses, and most of those responses are partial responses. Now, when it comes to actually deaths, and I think that's important to look there, that the number of deaths were 15 in cases of daratumumab, compared to patients on active monitoring, which were 26. So numerically higher amount of deaths in cases of active monitoring. Most of those were related to progression of the disease. But there are things I were called as adverse events, which are not clear to me, because those patients on active monitoring did not actually receive anything to cause an adverse events for them. But if you look into the time to myeloma treatments, it was not reached in cases of being on daratumumab, which is technically a treatment, compared to active monitoring, which was close to 50 months. So, and when it happens to what type of therapies those patients got, this is a study that was done in an era prior to anti-CD38 being used more widely, but most of those patients were treated on VRD based regimens, and a minority of patients that actually receive anti-CD38 based therapies. And when you look at the progression-free survival number 2, it's still being slightly better in cases of daratumumab compared to active monitoring.
What can you tell us about survival?
I think this is one of the most sort of appealing points used for many of us who is supportive for a smoldering myeloma treatment, is that the overall survival was better in patients who got daratumumab compared to active monitoring. The 5-year overall survival was 93% in cases of daratumumab, and around 87% in active monitoring, which gives you around 6% better survival at 5 years between those groups. And I think this is a secondary endpoint. So let's remember that this means, it's nice to see the overall survival, but we cannot be very definite about it being a secondary endpoint there. But and you can see also that progression of the disease and active monitoring was a reason of death, as we just indicated. So there are around 6 extra cases that the death was related to progression of disease and active monitoring. So it's always good to see overall survival benefit there, but few caveats to this. This is being a secondary endpoint, so need to keep that in mind. The other thing is the fact that most patients, when they got actually diagnosed with multiple myeloma, they got treated with regimens that we currently don't use as much, including lower use of quad-based therapies in general. And even when it comes to triplet-based regimens, we're talking about sizable number of patients getting VRD, but there are patients who get doublet-based regimens or regimens that we don't use in much in the US, including Cytoxan-based triplet and so on. And maybe for an international study that this is what is being offered, but I just want to warn everybody that this is maybe not something we do much in the US.
And how is treatment tolerated?
So, daratumumab is a good drug in a way that is really tolerated much better than Revlimid, for example. Remember, many of those smoldering myeloma studies were done previously using Revlimid. So it seems, daratumumab is more tolerated compared to other regimens that have been used before. And I think the only thing I would warn, the listeners about is that probably the pneumonia. You can see pneumonia happening more often, around 3% higher in cases of daratumumab, especially in the winter season and having all, some sort of uprise of cases of viral illnesses. We need to be a little bit careful about that. But, adverse events that results in death was minimal in both of those interventions, and even second primary malignancies were similar. So this is quite safe. Product to use, to be honest, with minimal side effects, as you can see on the slide.
So what is the key takeaways from this study?
So as you can see, the investigator conclusions per the study conclusions presented was that the use of daratumumab did improve progression-free survival, number one, and number two, and also improved overall survival compared to active monitoring, with being a favorable agent to use. That means there is some increment in side effects, but those increment of side effects are not, for example, related to more secondary malignancies, which we worry about in cases of lenalidomide. So the investigator did conclude that early treatment with single-agent daratumumab can offer patients with high-risk smoldering myeloma an opportunity to improve their outcomes, with a little bit of a caveat that most of this improvement has to do with the slim crab criteria and rather the anemia and high calcium levels, rather than actually avoiding fractures, which were similar in both groups, and also avoiding interstitial disease. And I think, this is fair sort of conclusions, but we need to take that with a little bit of a grain of salt, because the fact that nowadays we have really regimens that are 4 drugs that work on almost 5+% of patients compared to 2/3 of patients, make us, discuss that with patients in the clinic to better kind of come up with what works best for them.
So let's just talk about how you see this being incorporated in your practice. Before we go there, obviously before this trial, we've had Revlimid plus or minus dexamethasone that has also been shown to improve, progression-free survival, at least in smoldering myeloma. And some of the myeloma KOLs have adopted that approach. Some have not. What has your practice been for smoldering myeloma to date?
So up until now, actually, we observe all patients with smoldering myeloma. Before the era of AQUILA study, certainly we were observing all patients with smoldering myeloma, but we do actually observe those patients with more frequent observation periods compared even with what AQUILA study did. For example, the AQUILA study, the bone marrow biopsy was done up to 2 years, in between assessments, and imaging can be done anything between 1 to 2 years. So we sometimes do more imaging and or bone marrow biopsy in patients. Specifically, we worry about their high risk of progression. And I do think, our approach is mostly based on to not making any decision based on any single sort of measurement of myeloma proteins and or assessment. Because even if you look at AQUILA study, those patients were not started immediately on treatments once they got diagnosed with smoldering myeloma. On average, it took some of them, close to 9 months plus to get actually started on treatment, even if they randomized to daratumumab. So we actually tend to assess those patients more than one time before making a decision to do any sort of intervention. And in cases of evolving sort of myeloma protein, where patients' myeloma protein is going up as well as other markers, then consideration of actual treatment for myeloma can be sometimes discussed with patients. But all in all, even after the results of AQUILA study, we are really hesitant to start patients on single-agent daratumumab for smoldering myeloma, given the fact that we really monitor patients very well. And I think for somebody like me, it's reassuring to see that in randomized fashion, you really don't see acute renal failure. You don't really see much of bone disease difference between the two approaches.
So, and your own practice, even if daratumumab gets approved, it will not be a wholehearted start everybody on daratumumab-based approach. For your high-risk patients, would you consider it? Or I think what I'm getting from you is even for high risk, you're going to just watch them more closely and intervene?
Yeah, I think this is mostly the probably the general kind of way of managing those patients. But to be honest, nowadays I'm actually mentioning the results of AQUILA study to patients, including the good things and some limitations of it. And so far, I didn't have a patient who got interested to start the treatment. I think patients do appreciate having a treatment-free sort of interval, even if you do more frequent assessments on them. But in the future, if this agent become available, I think those patients who get diagnosed with high risk smoldering myeloma, in my opinion, should be rechecked and make sure that they actually have high risk smoldering myeloma. Somebody like yourself and myself who does lots of patient care related to plasma cell disorders, we see many of those patients compared to community oncologists where maybe they don't really look into all the aspects of high risk designation in a way, and specifically with this definition being changing. So I do suggest that those patients listen to the treatment option that they may have, including, for example, daratumumab, if it's got approved, and they kind of get to know what does it mean to be on it, for how long they need to be on it, and what is the benefit they're getting out of it. Because many patients may believe if I take daratumumab, that means I'm not getting myeloma anytime soon. But this is not necessarily true, because the study did show that some patients did progress even when they actually got the daratumumab, but the progression events were lower compared to the active monitoring. So I do actually think that there may be a role of some personalized care in specific patients. So in my example, if I have patients who are older, who I'm really worried about them coming to do those testing that often, and they have high risk smoldering myeloma, maybe at that time I could have considered using single agent daratumumab for up to 3 years with them. And I think they may be considering that, because that may allow them to, to not to do those frequent testing. But I think in general, our approach, and even my approach of treating those smoldering myeloma patients, continues to be really observation for now.
But for those that you do decide to ultimately treat, is it going to be daratumumab? Is it going to be Revlimid? Is it going to be both?
So if I choose a treatment, it would likely be daratumumab. Daratumumab is a safer drug than Revlimid, and also it's a limited duration for 3 years. It's a drug that, is given once a month after you start it, so it also become more convenient than daily dosing. So if in case that I decided to treat a high-risk smoldering myeloma patient, I would rather choose daratumumab than other things.
Well, I really want to thank you for taking the time out to uh, talk to us and review the data from this trial. And I am sure I'll be reaching out to you again to talk to us about some new and breaking news in myeloma again in the not too distant future.
Thank you so much for having me. And this is really an exciting study, and hopefully the listeners get some benefit out of the talk.
I'm sure they will. Thank you.
Thanks.